let's talk about the function of the palate first. There are certain techniques that we use in order to evaluate the function of the soft palate. This comes under concern in cleft palate and in conditions of what we call pharyngeal palatal incompetency. Because the palate hangs down at an angle, it has a knee action. Actually, it's the middle of the palate that does the closing, and the end is left down. So in closing, it does this action. And look at the end of the petrous portion of the temporal bone. Right at the end, right here in front of the occipital condyle. Now right there is the origin of the levator muscle. And you see its direction then would pull the palate upward and backward in the middle. And because it comes down in sort of a sling, so it closes it in from the side as well as from the bottom. Now it's a vital part of our speech. And as the air comes up, it is valved at various openings. Certain sounds, for instance, close it off altogether. Well, that G is made by a complete closure. So in that sound, the palate is at a maximum. It's also there in the swallow. Now also, some of the vowel sounds, oo, ah, mostly oo, have the palate very close to the roof of the nasopharynx. Many of the sounds like N, M, it's almost at rest. But anytime we have one of the plosives or one of the fricative sounds, sh, t, p, the P, the B, even the M, the lips come together, and the valve has to close in order to get the air through the mouth. Now, in a cleft palate individual that can't close off there, what he tries to do is to close off in this valve here in the nose here. So he will pinch his nose like so in order to talk. But in order to get his lips to work, he has to eliminate the air coming through in order to build up pressure. Now keep in mind, this is just not an up and down function. The palate is squeezed in from the sides also. Now, the nasal cavity is a resonance chamber. So if it's not open, we talk like we got a cold, because the nasal cavity is filled with fluid and the sounds are baffled. Some people with chronic allergies always talk like that. Now, the reason for the hooking action is because on the ends of the soft palate you have two muscles attached. This is the muscle to the tongue from the palate. That's in the anterior pillar of the fauces, and then the pharyngeal palatinus in the posterior column of the fauces. So they offer a resistance to the backward movement of the ends of the palate, and this explains the knee action. Now, in their position and in their action, they also have a sphincter action when a bolus of food goes through the throat. So they contract down and pull the palate and squeeze the food between the tongue and between the palate. These side muscles become active in a cleft palate individual, and they're joined by a horizontal group of fibers at the level of the anterior arch of the atlas within the superior constrictor. This is called Passiveness Cushion. As I said, when I first came to California, I made all of my own speech appliances. And we aimed the speech bulb at the Passiveness Cushion. And we made it large enough to fill the part of the nasal cavity to help them valve down in making speech sounds. And what we did then was to teach the patient to speak by using the swallowing muscles first. Now, the tensor vivi palatini muscle comes off of the scaphoid fossa. And the scaphoid fossa is between the two pterygoid plates. And right there is the scaphoid fossa. This muscle then runs down, and its tendon then hooks around the hook of the hamulus, where it then runs horizontally and hooks at the midline of the soft palate. It's a very unique arrangement for the control of the up and down movement of the palate, because at rest it can't do anything to the palate except stiffen it a little bit. But after the tensor has raised the palate, it is in a position to lower it and bring it back down. Therefore, these two muscles working together lift and lower the palate and permit this delicate movement then of the soft palate in speech. One of the things that you'll run into in orthodontic cases is patients that had posterior clefts or bilateral clefts in which a pharyngeal flap has been placed. The pharyngeal flap is made from the throat wall, and usually they will come down in the throat, make a horizontal incision, make a vertical incision, and take the fascia and the muscles from the pre-vertebral area. They will then raise that and fold it around a little bit and go in the back of the palate and split the palate vertically. Very delicate piece of surgery. Then they insert the soft palate into that flap that they raised off of the pharynx. Now there's another procedure that you will see, and that is what is called a pushback procedure. They will go in and take all of the tissue off of the palate, take it completely away in back of the incisive canal, and they will take the whole palate in addition to the time that they did the pharyngeal flap and do what they call a pushback. The palate will then granulate over and form another epithelium. But they do that to take the tension out of the palate when they try to close it posteriorly. And with the expert care that they give now and the waiting until the child is a little bit older, a lot of times the surgeon used to go in and try to close the palate in the first 2 weeks of life. Now they wait to 2.5 and 3. Some patients will have a very obtuse angle from the palate to the angle of the soft palate. Then you see these very precipitous angles of the palate. Usually this is class 3 with a very restricted maxilla. Now the tongue and the soft palate can't be in the same place at the same time. So usually when you see a precipitous drop to the soft palate, the tongue is low. And this is a condition we see in class 3. So all of this bony morphology. So to be completely sophisticated in the field of orthodontics, you need to look at that. First of all, their names. Anything that goes to the head is called capitis. Now the muscles, for instance, the trapezius is a trapezoid shape. So by the names themselves, you can begin to figure out what the muscle is. So that will be, number one, that will be helpful. Now the next thing is to look at these groups of muscle. And these are the pre-vertebral groups. These run up and down here, and also it's held in by this pharyngeal raphe that comes up and down right through here. And of course in here also there are capsules around each one of these joints. So we can look at the pre-vertebral group. Then next here we can look at the sub-occipital groups. that run up and down in between the base of the skull and the spinous processes. If it runs on the spine, it's a spinalis. So this will help you then with the rectus muscles that run out so that the vertebra then can be stabilized and stabilize the head. So the muscles that run up from the atlas, and this is all to tie all of these things together. So if we look up in here, you have to remember that there is a lot of sheaths of fascia in the neck. You've got muscles and ligaments running between each one of the vertebrae. So everything is tried to stabilize, and then by the anatomy itself, you have a sort of a lock, a cup shape of one fitting on top of the other. These are slanted in this direction, these are slanted in that direction. So that forms a sort of a pyramid. So there's sort of a locking device there that we have naturally. We have a group of intermediate muscles. These run up the neck, the Splenius Capitis coming up here. That's where that gets its name. It runs up here, and this is the big muscle that runs up and down the vertebra in the back. So these muscles then are almost continuous in action all the time you're sitting up or standing up. Now you understand why people are so miserable when they have a problem with the neck, because that's our foundation. So in this next circle, in the intermediate, we find the scalenus muscles, which are like the ties on a tent. They're coming out all the way out to the clavicle, and they're trying to stabilize them in the neck here, side to side. These then attach to the head and operate against the occipital condyles. Everything comes to the occipital condyles. Those are what the head is sitting on. Now these then pass up through the skull, in which there is then the scalp. The scalp is a very heavy fascia and a ponerosis that literally sits right down and pulls down on the skull in all directions. There are little muscles here that hold the scalp down, and so you can pull the scalp back. Then we have the front, we have these frontalis muscles. Then I mentioned this band that comes around here, which is a thickening of this fascia going over the top of the coronal suture. The first and most important and the largest and strongest and most active is the temporalis. The capacity or power of a muscle is measured by its physiologic cross-section. And the reason that we almost disregard the temporalis is because it's under this fascia. This is a leopard skull. If you will notice here, his temporalis comes all the way back here to a crest at the top of his neck. Now, if you notice the angle of this pull, notice the angle of the coronoid process. Look how the coronoid process dominates his mandible. Now, his occlusion is a shear type. His lower teeth fit completely inside his upper teeth. What's a dog do when he starts to get mad? He shows his canines, doesn't he? When he fights, what does he do? He throws these. These are lancers. And he cuts with them. Okay. Now, when he starts to bite, he can bite with a great deal of speed. All right, his condyle's down here, and look at the lever he has. And this permits him then to move out here with a great deal of speed. So the temporalis is the dominant muscle in all carnivores, and it is a shear occlusion. Now we move over to our friend the horse. If he has them, they're these little tiny things, much smaller than the laterals and centrals. He will pinch. He pinches his food like grass. Now his occlusion then is one of moving side to side. So he has a strong lateral component in his jaw. And if you notice now, this whole ridge out here is for the attachment of the master muscle. And look at the dominance now of his masseter muscle. And look at the embarrassing small little temporal fossa here. So like we saw the temporalis dominate the carnivore, the masseter dominates the herbivore. Now, looking from the inside, he also has a fairly good internal pterygoid, because the internal pterygoid also moves and stabilizes the jaw side to side. It's very interesting, the beaver, because he has a coronoid and an angular process that are about the same size. He doesn't have very much of an eminence. He has a plane on which the condyle runs. And they have actually two joints. They have a truly dual bite, because they have an occlusion that they can bite out in front with the incisor, and then to chew grain, they throw it in the mouth like a squirrel. The squirrel will put a nut in his cheeks, and then he'll go and set up and chew it. But he has to break the nut with his incisor. Now we come up to the omnivore. The pig is an omnivore. The form of his mandible is a little bit more like ours. But in the human, we have all three. We bite, we use our incisors. We cut with our canines, like you bite a piece of celery. And we grind with our molars. Now there's a very interesting thing about all occlusions in all animals. There is no position in which all of the teeth hit all of the other teeth at one time. There is no position in the natural occlusion where all the teeth contact at once. Now, in looking at the muscles of mastication then in man, all of these animals are mammals. This is a mammal, that's a mammal. We're a mammal. The rat is a mammal. They all suckle. Mammal means mammary gland. Mammals suck from the teeth. So we're all mammals, which means that prior to the time that the teeth come in, we are sucking the mother's breast, and the baby teeth come in. And then as the jaws grow, they get the permanent teeth. We're the same. But in man, instead of having a snout, his jaws now have shrunken. His head has grown out, and instead of being all no pores, he is bipedal. So there's been a transformation from a horizontal with a snout to a vertical position in which we see forward. That means the first business of the mandible is to hold the mandible up, because we are now vertical. Now you see a reason for the dominance of the temporalis muscle, because it has to hold the mandible up. So when I explain this to patients, TMJ patients and so forth, I call the temporalis the suspender. Yeah, these are the suspenders. That's holding his pants up. So when you think of the mandible, it's not just to support teeth. It's to hold all of these structures, and it holds the airway open. So you have to breathe. If I fracture a mandible right here through the middle foramen, this collapses, the patient's going to die. The same with the micrognathia at birth. The mandible is so small it can't hold the airway open. So it's a life-saving thing. So this means that the mandible is necessary for survival. If the brain goes 8 minutes without oxygen, you're dead. So we can only survive about 8 minutes without oxygen, because that's where we get our oxygen. And the mandible, we tend to forget that as dentists. So the temporalis then pulls the mandible up, but it also pulls it back. The posterior fibers of the temporalis run in this sulcus. That goes precisely over the glenoid fossa. This is all smooth and polished, because if you open the mandible here, these muscles have to stretch. And as we close, it pulls back. Now this is directly opposed by a muscle that runs at right angles in the opposite direction, and almost as big as the masseter is the external pterygoid. If this muscle pulls it back, the external pterygoid pulls it forward. So condyle position is determined by two muscles. A ligament cannot withstand permanent deformation. The final position of a condyle is determined not by ligament, but by muscle. The ligament will establish border movements, and it will produce the limits, but the center position and the rest position are determined by muscle. For a long time, dentists tried to push a condyle all the way back into the fossa. And of course, it would be distal to the habitual occlusion of the teeth. But there has to be an area of freedom for movement in a joint, any joint in the body. That was the old terminal hinge. So they used that for their rehabilitation, but it wouldn't hold. The patient would want to have some freedom, so they would gradually develop freedom in the joint. All right, now, if I want to move a condyle back, all I do is tighten up the posterior fibers of the temporalis like so. So you can strap up one of these things and play around with it and see how muscle tension then actually positions the condyle. Now the other thing here is what happens to the condyle head if I deliberately open the bite. I put in a bite plate or I extrude the posterior teeth. See how I load the joint. Now what have I done with the condyle? Compressed it. Now the internal pterygoids are designed to have a strong lateral vector. And these are the lateral stabilizers. The two temporalis and the two master muscles can stabilize vertically. Now if you can pick up a mandible and look at it, we use progressive torque in the lower arch. Okay. Now one of the things you will notice, the angulation or the torque on the lower third molar is directly in line with the direction of the internal pterygoid. This is the reason why the progressive torque in the lower arch, and you can see it here on this side very well. There's the long axis of the muscle. There's the long axis of the tooth. Now, the very last muscle that I talk about in the muscles of mastication is the master. It has two heads. It has a superficial part and a deep part. And it runs up to the zygoma and to the zygomatic arch. The deep portion are almost exactly vertical. The master is in a position to close and to grind. It can also assist the external pterygoid in holding the mandible forward. I suppose that's the reason we can still survive if we fracture a condyle. First of all, let me give you a little lecture on growth forecasting. Forecasting or prediction has been common to orthodontics ever since its beginning. In fact, any treatment plan is a forecast. It's a statement that you can do what you say you're going to do or you wouldn't plan it. Now, around the turn of the century, growth forecasting was based on the treatment because it was assumed that treatment made the mandible grow and the structures of the face could be influenced remarkably with treatment. So a prediction of the face was a prediction of treatment. Now along in the 20s, people had realized that that wasn't always the case. Now we realized then that everything could not be moved around with impunity. When it was recognized that this had to be a concern and that there were limits to what we could do in the orthodontic frame of reference. Now some other things happened in the 1920s, and this was Darcy Thompson's work, in which he showed the strong part that genetic plays, that indeed function may have limitations in what it can do in the production of a form. So we began interested in the constellation of patterns. Now the first substantial objection to the old idea of functional morphology was the advent of the rentgenographic cephalometrics. When he showed the orderliness of growth. Now this was heightened then by Brody's work on a serial basis, where he went one step further and called it a constancy of the pattern. Therefore the second prediction then was a constancy of the pattern. At the same time, the early evidence with cephalometrics seemed to indicate that the basic structure was indeed immutable. These were based on the primary and secondary edgewise therapy published in 1938. So the pendulum swung all the way over from mutability to immutability. This was followed then by a pendulum swing toward waiting for all the teeth. If you couldn't do anything with the structure, then all you could do would be to adjust the teeth. And if the pattern was going to be constant, all you had to do was to look at the pattern and assume that that was going to stay like it was. So that, in fact, became a form of prediction. But the waiting and that idea led to a plethora of extraction in orthodontics. But people began to be concerned about that because it was the zenith of the doctrine of limitations. And they began to look back on some of the older cases they treated without extraction, and in many cases they turned out well. And the idea was now that all people didn't grow in the original pattern, straight lines. In some, the face was swinging outward, the chin was coming forward, and in others, the chin was going backward. So when I came into orthodontics, this was the stage of it. For instance, if you had a class 2 malocclusion and the chin was going to grow forward, growth could be an assistant then in the treatment of the case. But if the chin was going to grow downward or downward and backward in a class 2 case, it would work against the treatment and to the detriment of the mechanics. So when I came into orthodontics in 1947, we were trying to look at faces and try to determine what was the likelihood of the future development. Some other things were happening at the same time. Downs came up with his analysis. Now another thing that was beginning to loom was that with treatment some of the patients didn't behave as it would assume that they would. Now the question still remained, was orthodontics capable of changing the pattern? And so when I came in to work with the tomogram, with the laminograph unit, it was thought that the behavior of the profile was dependent on what took place in the joint area. As I explained to you before, Brody's idea was that the condyle was the site of growth of the lower jaw. And if somehow we could get the information out of the joint and apply that to the face, we might be able to predict what the face was going to do. So in 1950, I was invited to go to Dr. Downs' home for dinner. We had a very nice roast beef dinner, and we went into his study. And Downs was not a very forceful person. And so I finally had to ask, okay, Bill, what's on your mind? Well, I think you ought to spend your life work in prediction. Are you out of your mind? Don't you know all the variation? Don't you know that this is a complication of the cranial base, and muscles, and influences of treatment? Yeah, I know all that. But you have to treat the patient. I know all of that, but you have to make a treatment plan. What goes on up here is determined by what takes place back here. And with your laminograph, you're the only one that has the view that would give us the answers, maybe. So the original idea of forecasting was not mine. It was William Bertram Downs.